Bismillah ar-Rahman ar-Rahim. Our lecture today will be about hepatic encephalopathy and liver failure. Regarding these two topics, by the end of this lecture, all of you should be aware of definition, pathogenesis, clinical picture, and treatment. On your right hand side, you will find the gross picture of the normal liver and the cirrhotic liver. As you see, the normal liver has a regular border, smooth and glistening shiny surface. However, the cirrhotic liver has irregular border, nodular surface, and it is very important for you when dealing with your patient to differentiate whether he has a normal liver or a cirrhotic liver, because hepatic encephalopathy may occur in a patient with normal liver or cirrhotic liver, and acute liver failure may occur in a patient with normal liver or in a patient with chronic liver disease and liver cirrhosis. Differentiation between a normal liver and a cirrhotic liver can be made by many parameters, including history, clinical picture, laboratory investigations, and imaging. All these parameters are very important to differentiate because our treatment will of course differ from this patient to the other. This figure shows the natural course of chronic liver disease. On your left hand side, you have the normal liver with the most common, and one of the most common etiologies for chronic liver disease is HCV infection. Patients with HCV infection may spontaneously clear the virus in about 15 to 20% of patients. However, the remaining 75 to 85% of patients will develop chronic hepatitis. By chronic hepatitis, we mean persistent inflammation of the liver lasting for more than 6 months. During the stage of chronic hepatitis and at the level of the hepatic lobule, histopathologically, we will have necroinflammatory changes and fibrous tissue laydown. When fibrous tissue laydown is extensive, it will lead to the occurrence of liver cirrhosis. Liver cirrhosis will be at first compensated, then it will be decompensated. And by decompensated cirrhosis, we mean cirrhotic patients who develop ascites, bleeding varices, and or encephalopathy. Thereafter, the patients may develop hepatocellular carcinoma. Hepatocellular carcinoma may develop on top of compensated cirrhotic liver and also on top of decompensated cirrhosis. And in certain etiologies like hepatitis B, hepatocellular carcinoma may even develop in patients with chronic hepatitis without the presence of cirrhosis. Hepatic encephalopathy. By definition, hepatic encephalopathy is a brain dysfunction caused by liver insufficiency and or portosystemic shunts. It manifests as wide spectrum of neurological and or psychiatric abnormalities, ranging from subclinical alterations to coma. Here it is clear that hepatic encephalopathy may occur in a patient with normal liver. For example, if you have a patient with portal vein thrombosis, he will develop portosystemic collaterals and portosystemic shunts. These shunts will be responsible for the occurrence of hepatic encephalopathy in a patient with normal liver. Hepatic encephalopathy is the second most common major complication in cirrhosis following ascites. Really, it has a heavy burden because hospitalization is common and present a burden on patients and the healthcare system with considerable cost, high morbidity, and mortality. In a patient with hepatic encephalopathy, you have to remember three main stations: the gut, the liver, and the brain. Usually, in a patient with encephalopathy, the nitrogenous overload, ammonia, and toxic substances originating from the gut will pass to the compromised cirrhotic liver or will bypass the cirrhotic liver through the portosystemic shunts to reach the systemic circulation and the brain, inducing manifestations of hepatic encephalopathy. Pathogenesis of hepatic encephalopathy. On management of a patient with hepatic encephalopathy, careful history taking is very important because identification of the precipitating factor of encephalopathy is of paramount importance as it will constitute the mainstay of treatment. And here we have to take proper history from the patient himself and from his family. The common precipitating factors include hypovolemia from the use of excessive diuresis and or paracentesis, especially without volume replacement with human albumin, hyponatremia and electrolyte imbalance, sepsis due to infection elsewhere in the body, drugs, whether hepatotoxic drugs or some drugs that may affect the brain function itself, like benzodiazepines, high protein diet, GIT bleeding in the form of hematemesis and or melena, constipation, concomitant disorder including anemia and alcohol intake. Ammonia is the most important theory in the pathogenesis of hepatic encephalopathy. However, other toxic substances and other factors are sharing in the pathogenesis of the disease, including manganese, systemic inflammatory response, enhanced oxidative stress, hyponatremia, sarcopenia, and gut microbiota. Recently, some reports are talking about the toxic effect of manganese on the brain cells and its role in the pathogenesis of encephalopathy. Regarding systemic inflammatory response and sepsis with the release of certain cytokines together with the occurrence of hyponatremia, both these factors may facilitate the effect of ammonia on the brain cells. Sarcopenia, which means decreased skeletal muscle bulk, is a common finding in patients with cirrhosis, and it has an important role in the pathogenesis, and we will discuss this point in the next few slides. Very recently, and a novel approach and a novel point in the pathogenesis of hepatic encephalopathy is gut microbiota. Nowadays, it is becoming evident that no single entity is responsible for hepatic encephalopathy, but rather it is a synergistic effect of multiple mechanisms. As I told you before, in a patient with hepatic encephalopathy, you have to remember three main stations: the gut, the liver, and the brain. This diagram shows the increased amount of ammonia originating from the gut and bypassing the liver through portosystemic shunts or passing through the compromised liver to reach the systemic circulation. Normally, ammonia, which is present in the systemic circulation, should be consumed partially by the skeletal muscle bulk. And if you have a cirrhotic patient with diminished skeletal muscle bulk or who has excess ammonia production in the systemic circulation, this ammonia will pass to the brain and especially to the astrocyte to induce manifestations of hepatic encephalopathy. It is hypothesized that the delivery of ammonia from the capillaries to the astrocyte, and the astrocyte is considered to be the key cell responsible for the pathogenesis of encephalopathy. Upon delivery of this ammonia to the astrocyte, glutamate will be transformed into glutamine by the action of glutamine synthetase enzyme, and the excess amount of glutamine within the astrocyte will make it to imbibe water from the surrounding structures and to swollen, inducing a low grade of cerebral edema, which is responsible for the manifestations of the disease. This is the West Haven criteria for diagnosis and the clinical staging of hepatic encephalopathy. On your left-hand side, the first vertical column shows the different grades, starting from minimal and grade 1 then grade 2, 3, and 4. Minimal and grade 1 are considered to be covert encephalopathy, and covert is clinically not manifested disease. However, overt is clinically manifested disease. The patient with hepatic encephalopathy, as we said in the hepatic encephalopathy can be classified according to the underlying disease into type A, B, and C. Severity of manifestation according to Westhaven criteria, according to the time course into episodic, recurrent, and persistent. Existence of precipitating factors including non-precipitated and precipitated hepatic encephalopathy, acute on chronic liver failure. Regarding minimal encephalopathy, the presence of test-dependent or clinical signs of brain dysfunction in patients with chronic liver disease who are not disoriented or display asterixis. The areas with impairment are attention, visual perception, speed of information processing, fine motor skills, and short-term memory. And as you see, these areas are usually testing very fine functions, whether visual, auditory, or motor functions. And the covert hepatic encephalopathy includes, as we said before in the Westhaven criteria, both minimal encephalopathy and grade 1. We have to pay some attention to minimal hepatic encephalopathy because patients with minimal encephalopathy have tendency to develop overt encephalopathy. Liver transplantation should be considered in patients with minimal hepatic encephalopathy. Minimal encephalopathy impairs health-related quality of life, patients' ability to work and daily function, including driving skills, with increased incidence of car accidents. And in the East, in some countries, in the East and West, in some countries, they do testing for minimal encephalopathy for their patients because, as you know, alcoholic liver disease is common in some countries, and this entity, which is minimal encephalopathy, cannot be diagnosed except by psychometric test. Here we have some questions regarding minimal encephalopathy and covert encephalopathy. Who to test, why to test, what to test, and how to test. Ideally, all patients should be tested for minimal hepatic encephalopathy. However, this is not practical. Therefore, we have to test high-risk patients. Why to test? Because testing has a prognostic value and it actually helps the patient and the caregiver to accurately evaluate the disease. What to test? As we said, minimal encephalopathy is related to certain areas in the brain. Therefore, we will test areas with impairments, which are attention, visual and auditory perception, speed of information processing, fine motor skills, and short-term memory. Then, how to test? This is a very simple way for testing, which is number connection test. And as you see, the patient is given this charge with different numbers in these circles, and he has to connect the numbers serially together, number 1 to 2 to 3, and so on. Another sample test, which is line tracing test. Of course, it can test the fine motor function of the patient. Other methods for testing of minimal and covert encephalopathy are critical flicker frequency test, which is a psychophysiological tool defined as the frequency at which a fused light appears to be flickering to the observer. Actually, other tests can be done using the computers, the iPad, and the smartphones, testing different brain functions like continuous reaction time test, testing the auditory stimuli, and another inhibitory control test, which is a computerized test of response inhibition and working memory. Other psychometric tests include Stroop test and the scan test, and these different psychometric tests, as I told you before, can be applied through the computers, iPad, and smartphones. And it is very important nowadays in the Western countries to use these tools for self-assessment for encephalopathy, because it can help the patient to receive his medication or to determine the timing that he can ask for the help of his clinical practitioner. Then EEG changes. EEG has certain characteristic features in patients with hepatic encephalopathy. However, it is not pathognomonic. Few words about critical flicker frequency. It's a new diagnostic bedside test for minimal hepatic encephalopathy. It measures visual discrimination and general arousal. Patients are first instructed and trained about the procedure. Then measurement of critical flicker frequency thresholds is done by intrafoveal stimulation with a luminous diode, decreasing the frequency of the light pulses from 60 Hz downward. Critical flicker frequency threshold is determined as the frequency uh, when it is less than 39 Hz. This figure shows the different grades of encephalopathy matching with the measurement of the critical flicker frequency and the appearance of the clinical symptoms. Is it mandatory to measure blood ammonia level? Is it diagnostic? Is it helpful? We have to answer these questions. Increased blood ammonia alone does not add any diagnostic, staging, or prognostic value for hepatic encephalopathy in patients with chronic liver disease. A normal value calls for diagnostic re-evaluation. What does this mean? This means that we do not depend on measurement of blood ammonia for diagnosis of hepatic encephalopathy. However, as we said previously in the definition, we depend on the presence of chronic liver disease plus manifestations of encephalopathy. And if there is no liver disease, we depend on the presence of portosystemic shunts. The value and the actual value of measurement of blood ammonia, if you have a patient with coma and you are searching for the cause of coma, if you measure blood ammonia and you find it normal, then you have to reassess your patient and consider him as non-hepatic coma. However, in patients with chronic liver disease and for ammonia-lowering drugs, repeated measurement of blood ammonia may be helpful to test the efficacy and to stop the drugs. Management of hepatic encephalopathy. At first, you have to exclude non-hepatic causes of altered mentation. Then to identify and correct precipitating factor, because nearly about 90% of patients can be treated with just correction of the precipitating factor. Therefore, you have to look for the precipitating factor and correct. For example, hypovolemia. Please avoid the excessive use of diuretics and or paracentesis, and always remember that some ascites or peripheral edema is better than hepatic encephalopathy. Then you have to search and correct other precipitating factors. Differential diagnosis. You have to differentiate other similar conditions of disturbed sensorium from hepatic encephalopathy. Actually, the list of differential diagnosis is very wide, but sometimes it is very important to differentiate these conditions from hepatic encephalopathy, especially in patients with chronic liver disease, like diabetic complications, alcohol intoxication, drugs, neuroinfections, electrolyte imbalance, epilepsy, psychiatric disorders, intracranial bleeding, stroke, brain lesions, obstructive sleep apnea, hyponatremia, and uremic encephalopathy. And sometimes you may find both of the conditions together. You may find a patient with hepatic encephalopathy, for example, with head trauma inducing intracranial hemorrhage. And you may find a patient with liver cirrhosis, ascites, and hyponatremia together with hepatic encephalopathy. Therefore, differential diagnosis is important, and sometimes you may find both conditions as I told you. Lines of treatment of hepatic encephalopathy include the following: diet, lactulose, neomycin, L-ornithine L-aspartate or LOLA, rifaximin, flagyl, enema, branched chain amino acid, flumazenil, L-dopa and bromocriptine, zinc, and probiotics. Regarding diet, I have to address that about 65 to 90% of cirrhotics have malnutrition and increase the incidence of hepatic encephalopathy. Protein restriction in patients with encephalopathy is controversial. Some centers allow protein even in patients with hepatic encephalopathy, others prohibit it completely for a certain duration. Much protein restriction should be avoided to avoid malnutrition and to maintain positive nitrogen balance. Non-animal protein in general might be better. Modify composition of diet to increase caloric nitrogen ratio. In general, high fiber diet is preferred, including increased amount of vegetables and fruits. Lactulose. It's non-absorbable disaccharides. It is considered to be the standard of care treatment for hepatic encephalopathy over 30 years, approved by FDA, and its mechanism of action is lactulose will be converted into lactate and acetate. Of course, it has a laxative effect, and the reduction of the transit time of the colonic content will help to reduce ammonia, together with the acetate inside the colonic lumen will increase the acidity of the lumen and will help for decontamination of the gut. It can be given in a dose of 15 to 30 milliliter oral intake 1 to 3 times daily. Actually, we can adjust the dose of lactulose according to the patient response. We can give the patient amount, as I said, up to 90 milliliter. Of course, it is a large amount. However, some patients may tolerate. And the goal for treatment is to have loose stool at least once or twice per day. It can be associated with some side effects. The most important of them is bloating, colics, and the sweet taste, and of course diarrhea. But it is very helpful in treatment. Neomycin, another FDA-approved drug, mainly locally acting aminoglycoside antibiotic. Its mechanism of action is affection of the intestinal flora to generate ammonia. It should be given in a dose of 3 to 6 grams per day orally in the first 3 days, then 1 to 2 grams per day thereafter. This is a very large dose of neomycin, and you have to notice that patients with chronic liver disease have vulnerable kidney, and this very large amount can be associated with absorption of the drug in about 4% of patients, and it may have nephrotoxic effect, and this is considered to be the main side effect. Metronidazole is a good alternative to neomycin. It can be given in a dose of 500 milligrams 3 times daily. It affects the intestinal flora. The main side effects of metronidazole is metallic taste, anorexia, and peripheral neuropathy with long-term use. It can be used as an alternative to antibiotic. Branched chain amino acid can be given either in intravenous or oral form. The oral branched chain amino acid is reported to have beneficial effects in patients with cirrhosis, especially in improving the nutritional status. Flumazenil is another molecule that can be given intravenous. It is an NXate. Its mechanism of action is benzodiazepine receptor antagonist. It can help some patients, so the general policy is to try to use this drug if the patient is improving. We can repeat it, and if not, no need to repeat it. So it helps only in arousal of the patients. Enema is The last but not least, enema is very important. It is very helpful in management of hepatic encephalopathy. L-ornithine L-aspartate or LOLA. It has both intravenous and oral forms. LOLA significantly reduced the blood ammonia levels in patients with hepatic encephalopathy. LOLA is a compound salt that stimulates ornithine transcarbamylase and carbamyl phosphate synthetase in the liver and is a substrate for formation of urea. It stimulates glutamine synthesis in skeletal muscle and consequently lowering ammonia concentration. So its main action is enhancement of the urea cycle to get rid of ammonia. LOLA has been most thoroughly evaluated in the setting of chronic hepatic encephalopathy. Randomized placebo-controlled double-blind studies were performed in Germany using an intravenous and an oral form of LOLA in patients with chronic encephalopathy, both of which demonstrated improvements in the number connection tests, ammonia values, and hepatic encephalopathy parameters, including mental state gradation and portosystemic encephalopathy index. So, LOLA can be used in both acute and chronic setting of hepatic encephalopathy. However, till now the guidelines approve it only for acute hepatic encephalopathy. Rifaximin, a minimally absorbable gut-selective rifamycin derivative with antibiotic activity against enteric, aerobic, and anaerobic microorganisms, which are important sources of ammonia. Being minimally absorbable, less than 0.4% in comparison with neomycin, which is 4%, rifaximin allows it to reach high concentration in the intestinal tract and to remain in the feces in its active form with minimal systemic side effects. In the market, rifaximin has two concentrations, either 200 mg or 550 mg oral tablets. It can be administered twice daily if 550 mg or 3 times daily if 200 mg. By the way, rifaximin was first approved for treatment of traveler's diarrhea, and thereafter, and after about few years, it has been approved by the FDA for treatment of hepatic encephalopathy and mainly for prophylaxis. The main side effects of rifaximin is nausea, vomiting, and abdominal pain, sometimes flatulence, diarrhea, tenesmus, headache, and also constipation. The main indication of rifaximin in treatment of hepatic encephalopathy is prophylaxis. It is recommended that patients with a history of recent acute hepatic encephalopathy should be maintained on rifaximin plus lactulose to reduce the risk of recurrent hepatic encephalopathy and related hospitalization. Now we came to the second part of our lecture, which is liver failure. The clinical course of acute liver failure is initiated with severe acute liver injury. This is characterized by 2 to 3 times elevation of transaminases as a marker of liver damage, associated with impaired liver function, that is to say, jaundice and coagulopathy. In terms of prolonged INR more than 1.5 in a patient without chronic liver disease. Severe acute liver injury defines a syndrome characterized by markers of liver damage, which is elevated serum transaminases and impaired liver function in terms of jaundice and prolonged INR, which usually precedes the clinical presentation of hepatic encephalopathy. Therefore, when you are confronting a patient with acute liver failure, you have to ask yourself an important question: whether this patient has previously a normal liver or cirrhotic liver. The difference is very big. Because acute liver failure coming on top of normal liver has much better prognosis than patient with acute liver failure coming on a background of cirrhotic liver, which we call acute on chronic liver failure. And as I told you in the previous slide, the main criteria for diagnosis of acute liver failure, especially in a patient with normal liver, is the occurrence of jaundice as a first manifestation, then it is followed by coagulopathy, and it should be a significant coagulopathy, which is determined by prolongation of INR more than 1.5 and the occurrence of bleeding tendency from everywhere, plus the appearance of hepatic encephalopathy. Once hepatic encephalopathy appears in this patient, we can consider him as acute liver failure. We have more than one classification for acute liver failure. According to the duration interval between the onset of jaundice and the appearance of the hepatic encephalopathy, we have the first classification, which is fulminant and subfulminant. Fulminant, the duration is less than 2 weeks. Subfulminant, duration is more than 2 weeks and less than 12 weeks. Another classification is hyperacute, acute, subacute, chronic, or acute on chronic. Hyperacute, less than 1 week. Acute, from 1 week to 4 weeks. Subacute, from 4 weeks to 12 weeks. Chronic duration is more than 12 weeks, and acute on chronic, which is manifestations of acute liver failure coming on a background of chronic liver disease, especially cirrhosis. This classification is very important. I mean that it is important to determine whether the patient has fulminant and hyperacute forms of liver failure or not. Why? Because fulminant and hyperacute forms of liver failure primarily occur on top of normal liver, and they are usually associated with cerebral edema and they carry better prognosis than other forms of liver failure. After achievement of the diagnostic criteria of acute liver failure, you have to search for the cause of acute liver failure. The main causes include viral, including hepatitis A, B, D, and E. HCV is very exceptional to cause acute liver failure. It can induce acute liver failure, especially in viral co-infection like with HIV. Other viruses which may be blamed are Epstein-Barr, cytomegalovirus, adenovirus, herpes simplex 126, and parvovirus B19, especially in aplastic anemia. Drugs are considered to be important etiology for acute liver failure, especially acetaminophen toxicity. Many people in the Western countries may have suicidal attempt with acetaminophen. The dose for inducing acute liver failure for acetaminophen should be a single dose which is more than 15 grams in non-alcoholic or daily dose of 3 to 8 grams in alcoholic malnourished patients. Acetaminophen induce acute liver failure by a certain mechanism, which is its metabolism into toxic intermediate metabolite. This intermediate metabolite induces massive liver necrosis and is normally cleared by glutathione, and the stores of the glutathione is decreased in alcoholic and malnourished patients. Other etiologies of acute liver failure include toxins and metabolic causes. The most important of metabolic causes are acute fatty liver of pregnancy, which is usually associated with preeclampsia, jaundice, hepatic encephalopathy, and fulminant hepatic failure in the 3rd trimester. Reyes syndrome, which is microvesicular acute fatty liver, together with vomiting and increased intracranial pressure, especially in children who have hypersensitivity to salicylates. Vascular causes include ischemic hepatitis, which is shock liver, which is one of the findings that can occur in patients submitted for open heart surgery after they were put in heart-lung machine. But Chiari syndrome and veno-occlusive diseases may present with acute thrombosis due to myeloproliferative disorders and other disorders, and its presentation is very variable. And one of the clinical presentation of Budd-Chiari syndrome and veno-occlusive disease is presentation by acute liver failure. Miscellaneous causes including Wilson disease, autoimmune hepatitis, massive tumor infiltration, for example lymphoma and carcinoma, and sometimes the etiology is unidentified. Regarding the clinical picture of a patient with acute liver failure, I think that it is clear for you now from the previous criteria that we have mentioned that should be fulfilled for diagnosis. Our patient should have jaundice, coagulopathy, which is bleeding diathesis due to reduced prothrombin activity and platelet count, resulting in epistaxis, vaginal bleeding, hematemesis, and or melena. Then the patient will suffer from hepatic encephalopathy. Regarding ascites, usually it is mild, and in some patients it can be tense. Cerebral edema. The commonest identifiable cause of death in fulminant hepatic failure is brain edema. The mechanism is unknown, but it is said that it can be either vasogenic or cytotoxic theory, leading to impaired cerebral blood flow and increased intracranial pressure. The signs of brain edema is universal: hyperventilation, systemic hypertension, abnormal pupillary reflexes, muscle rigidity, or decerebrate posture, and lately impaired brain stem functions and papilledema. So papilledema is not an early manifestation of cerebral edema. And once we are suspecting cerebral edema in a patient with acute liver failure, we have to start its treatment. One of the clinical manifestations of acute liver failure is fetor hepaticus. It's a sweetish fecal odor of the smell due to increased levels of methyl mercaptons, which are normally detoxified by the liver. Its significance is that it is a sure sign of liver failure when diagnosis is doubtful, and it carries a poor prognosis in fulminant hepatic failure as it may precede coma stage. So the prognosis is usually unfavorable in this patient. However, in patient with chronic liver disease, you may find the fetor hepaticus with fair prognosis in this patient. I mean short-term outcome, because in these patients usually the fetor hepaticus are attributed to the presence of portosystemic collaterals. However, in patients with acute liver failure, its presence is associated with poor prognosis. Sepsis is common in these patients because we know that liver is a part of the immune system, and its liver failure can be associated with sepsis. Metabolic disorders including hypoglycemia, acidosis, and sometimes alkalosis due to hyperkalemia, but most probably acidosis and is more common. Hypoxemia due to aspiration, atelectasis, infection, ARDS, and pulmonary hemorrhage. Renal failure may occur in patients with acetaminophen poisoning early and associated with about 95% mortality rate. However, in other causes of acute liver failure, it occurs late and usually associated with fluid retention. That is to say, it is a form of hepatorenal syndrome. Respiratory failure is also a common finding in patients with acute liver failure, usually due to adult respiratory distress syndrome and pulmonary hemorrhage. And by pulmonary hemorrhage, we mean the presence of blood within the alveoli. Regarding the laboratory investigations in patients with acute liver failure, I think it is clear for you now that we have to do a liver profile including serum bilirubin, prothrombin time, and factor V, which should be decreased by more than 50% of normal. Serum albumin decreased, ALT and AST increased, then decreased, and in a very advanced stage they may be even normal transaminases. Serum calcium, phosphorus, magnesium, and potassium usually decreased. Urea and creatinine can be increased. ABG, either acidosis or alkalosis, arterial blood ammonia is increased. Management. ICU management is mandatory. The goal is to support patients in whom prognosis is good till they recover and to move quickly to liver transplantation in patients with poor prognosis. Assisting liver support systems like MARS can be used as a bridge before liver transplantation. Regarding nutrition, enteral is better than parenteral feeding. Aggressively correct low levels of glucose, phosphorus, calcium, potassium, and magnesium. You have to give a sufficient amount of calories to your patient. You have to correct coagulopathy by giving vitamin K, fresh frozen plasma, and the platelet transfusion if needed. Also, we have to apply measures for treatment of hepatic encephalopathy. Measures for brain edema. It is very important to treat brain edema in these patients by giving mannitol 20% intravenously. Usually we give our patients from 150 to 200 milliliter twice daily till intracranial pressure decreases. However, it is contraindicated in patients with renal failure. Also, other measures for treatment of brain edema is to raise the head about 10 degrees, avoiding hypoxia and hypotension. However, corticosteroids are not indicated in these patients. The corticosteroids proved to be not effective at all. Also, we have to anticipate and correct sepsis by empirical or specific antibiotics. We have to anticipate and correct renal failure by fluid volume expanders, dopamine, and with or without hemodialysis if needed. Anticipate and correct respiratory failure and metabolic abnormalities. Anticipation and correction is a very good policy in these patients, that is to say, identifying any abnormality and correcting it as early as possible. Because, as we said, the main goal is to support our patient to tide him over this critical period and to help for recovery without the need for liver transplant. And in some patients, of course, we may need liver transplant if they are not responding. There is a specific treatment in patients with acetaminophen poisoning, which is N-acetylcysteine, which is used to restore glutathione. Loading dose is 140 mg per kg, then 70 mg per kg every 4 hours for 17 doses. By the way, N-acetylcysteine is available in our country, and it can be also given for patients with severe alcoholic hepatitis, especially if they have prolonged cholestasis. And the last but not least is liver transplantation. Liver transplantation should be considered and indicated in patients with severe progressive liver failure. In conclusion, pathogenesis of hepatic encephalopathy is multifactorial. Ammonia is the most important theory. The mainstay of treatment of hepatic encephalopathy is to identify and correct the precipitating factor. Reduction of ammonia synthesis and absorption is the most important and approved step in treatment of hepatic encephalopathy. Liver failure could be acute, chronic, or acute on chronic. Brain edema is the most common complication of acute liver failure. Treatment of liver failure should depend on treatment of the cause, anticipation and the treatment of complications, and liver transplantation should be considered. Thank you for listening.